For the next section of my talk, I wanted to kind of go over, titled it Know Your Numbers. We're going to go over different facets, but I do believe there's evidence based in these Know Your Numbers, taken from several different guidelines. The first part that we'd like to know your numbers is going to concentrate on blood pressure. That is sometimes known as a silent killer because you can't always know where your blood pressure is unless it's on extreme values like very low or too high. A lot of people ask what the normal blood pressure is, and typically the statement would be that that top number called systolic number, you want less than 120 millimeters of mercury. The second number is when your heart's relaxing, so it's a lower number, and that number is called diastole or diastolic blood pressure, and that value we want less than 80. Typically what we're also indicating that blood pressure has some range. As you see on my slide there, we'll go over different ranges, but typically the hypertensive aspects is when we're worried when it's above 140 on the first number or above 90 on the second number. There is a new adage that at age 65, or that is above age 65, that a different goal would be for blood pressure control, and that first number is actually less than 150, and the second number still remains less than 80, but there's a little bit of permissive hypertension that we notice in people older than 65 that's allowable. So we don't want to overtreat someone, and those are kind of the guideline numbers for blood pressure. Those are important to know. The next facet that I wanted to go over is cholesterol. There are a number of elements within the cholesterol panel that's often drawn, and the goals nowadays can be somewhat confusing because they're dependent upon the clinical presence of what we call atherosclerotic heart disease or heart disease, meaning evidence of maybe a heart attack or having some work done on your heart arteries, also in combination with diabetes. And it also sometimes has to take into factor people that do not have those particular risk factors, kind of an assessment of what their risk might be over the next year using something called the Framingham Risk Assessment, which was kind of just a longitudinal study known in Framingham outside of Massachusetts. It gives us a risk factor of what your risk of heart attack might be in the next 10 years. And that can decide if it's really high, you might be more aggressive about your lowering of cholesterol values and those goals. If we look at total cholesterol, that's the overall value. In the old days, that's about all we had, but now we're trying to break it down into the good and bad. The total cholesterol itself, just less than 200. The other facet is triglycerides, and that's really important to have that lab drawn. Typically when you're fasting, we want that number normally to be less than 150. We get worried as it gets more elevated, and those can be more metabolic things that you're not breaking down the sweets or carbohydrates as quick. We often see that in the diabetic population. The other component is something called HDL or good cholesterol. That is actually the kind of cholesterol, the higher the better. And we'll say that, if you're greater than 60, that actually imposes a very low risk. It's beneficial. We do try to keep it so it's not less than 40. That imposes some additional risk, but most of the data now for cardiology is driven on the LDL, or called low density lipoproteins, a mouthful, but everyone generically kind of calls that bad cholesterol. The lower, the better. The adage is if you have, for example, coronary artery disease or diabetes, our goal now is to try to get that number less than 70. If you have multiple risk factors, maybe less than 100. And I said the other component is if you're looking at that Framingham risk assessment, it may depend on how much of a risk you are as to your actual goal. So you may have to speak with that specifically to your physician to know your exact goal. The next component is transitioning over to blood sugar. A lot of people call this the diabetes component towards that. What we're looking for is in a pre-diabetic state, or non-diabetic that is, we want your fingerstick blood sugars to be less than 125, and something called a hemoglobin A1C, which is an average value, and that's a percentage, and we want that number less than 6.5. There is elements that if those numbers are higher than 125 on the blood sugar itself, or higher than 6.5, then you are in the diabetic range, and certainly would have to speak with a physician about elements to treat that. My last category of know your numbers is body composition. We're breaking it down more into kind of a normalization process to height, because people do have different heights that allow them to carry different amounts of weight on their body frame. So we're trying to use something called the body mass index, or BMI for short. And that's really kind of your body mass divided by the square of your body height. So it takes height into consideration. Typically, the normal goal is about 18.5 to 25. And that's something you can look up on most calculated aspects on the internet to find. Our big concern is if that number is getting greater than 40, you're in a morbidly obese state. We really need to get that number down. And the last one is just kind of an easy measurement called abdominal circumference. And there's been some link with coronary artery disease on this. There is an element that is a difference between male and female. The females, we want that measured at the level of the belly button to be under 35 inches and the males under 40 inches because values above that are linked to coronary artery disease risk.